Measles is one of the most contagious viruses on Earth, and it can spread really rapidly. So as healthcare providers, we really need to be on the front line in preventing the spread of this infection. So the measles virus is spread airborne. That means if somebody is, say, in a clinic room and they cough, that can actually be contagious for up to 2 hours. And because it's so highly contagious, if you then have an unvaccinated person exposed to that, they have a 90% chance of coming down with measles. And for many people, it's a mild disease, but for others, they'll develop serious ear infections, pneumonia, and even encephalitis. In 2000, measles was eliminated from the United States, which means it's not consistently present. It's not endemic in the U.S. However, we still see cases every year, and they are due to either unvaccinated foreign visitors or travelers from the U.S. who are unvaccinated who pick up measles elsewhere, bring it back unknowingly, and especially if they come back to undervaccinated communities, that can spread. And we do have undervaccinated communities in Vermont, so this is something we need to keep in mind. It's important to remember that there's about a 10-day incubation period from when a patient is exposed to measles to when they start having symptoms. The first symptoms you see are fever, rhinorrhea, cough, and conjunctivitis. About 2 to 3 days after those symptoms start, you may be able to find coptic spots. So those are those spots on the inside of the cheek near the molars that look like tiny grains of salt with some erythema around them. And that is pathognomonic for measles. So if you see those, then the patient has measles. Then 2 to 3 days after that is when the rash starts. And the rash starts at the hairline at the top of the head and moves its way down the body and is in a macular formation. It can also be papular, and it can become confluent. So even though everyone associates measles with the measles rash, we really don't see it until many days into the illness, and patients are already contagious before that. So we really need to be vigilant in thinking about whether a patient who's coming in with fever, cough, runny nose, and conjunctivitis, have they been to an area that is either endemic for measles or where there's an outbreak? Is there any chance they have measles? Do they have coptic spots? So those are the things we can start looking for before the rash starts so we can catch this early. Because it's so hard to differentiate measles, especially in the early days when we really want to catch it, from other viruses, it's okay to call early, call the Department of Health, and run the case by them and ask them what they think. Public health officials at the health department are really your support system through this, and they're available 24/7. So they can help if you have a patient who you think might have measles or may have been exposed to measles, or maybe traveling to a measles endemic area or an area where there's an outbreak. They can help walk you through what labs to send, how to send them, how to facilitate that process, how to contain the potential spread, and then which patients need vaccines and which might need immunoglobulin if that's the case. Many of the diseases that vaccines prevent we don't see anymore because the vaccines are so effective. And so that's why we need to keep these infections at the forefront of our mind and think about them often, especially in patients who are not fully vaccinated. It's always important to remind families that there's no treatment for measles. The only thing we can do is prevent measles. And so when families hear about measles cases in the news, if there are ongoing outbreaks, that's another chance and another opportunity to talk about the importance of vaccination with your patients.